for today.
Sure. I'd like to welcome everybody. Actually, quite pleased to be able to introduce Dr. Okeanis E Vaou from, who's now from San Antonio. Uh, uh, Okeanis had, after training in neurology, came to BU, Boston Medical Center to train. First, she did a fellowship in movement disorders, and then she worked with us and did a fellowship in sleep, and has sort of cultivated both areas over the years. After spending some time in practice, coming back to us, then moving on to St. Elizabeth's, she's now relocated to San Antonio at the University of Texas Health, San Antonio. And she's now associate professor of neurology there. She works both in the neurology department and with the Neurodegenerative Institute there. So I hope I get all these things right. She's the director, she's the division chief, rather, for movement disorders and deep brain stimulation. And she's also runs a sleep clinic, a sleep and RBD clinic, rather, as part of the Glenn Biggs Institute of Alzheimer's Disease and Neurodegenerative Disorders down there. She's been quite active in both of these areas. And so I thought it'd be a natural to have her come and talk about the topic today of sleep and Parkinson's disease. And with that, I'd like to introduce Dr. Vaou.
Thank you so much. Thank you so much, Dr. Auerbach and Dr. Zinchuk, for having me, for inviting me. I'm very passionate about this topic. As a matter of fact, when I finished my movement fellowship, I wanted to learn more about sleep because I was seeing all these patients, and then sleep always came up. So I wanted to know more and more. So I took another year with Dr. Auerbach at BU, and it was so worth it. So now I understand more about sleep, and I think more people are focused in sleep and movement. And I also think I started a trend, Dr. Auerbach. There was another fellow of movement that followed me afterwards in sleep fellowship. So now I think we have 2 or 3 have come out of BU with movement and sleep. So these are my disclosures. So I would like to get started with an overview of Parkinson's. I understand not all of you are neurologists. So I would like to give you an overview of Parkinson's disease, which was first described by James Parkinson way back in 1817. It is a condition of loss of dopamine-producing cells in the brain. What we are seeing is that the incidence and prevalence is increasing over the years. In 2010, we're talking about 680,000 individuals having PD over the country. In 2020, we're thinking just shy of close to 1 million. And in 2030, it's probably going to be over 1 million, with that trajectory being quite steep. We don't know if it's overdiagnosis. There's a lot of theories. This could be, some people have called it an epidemic. It remains to be seen. The pathophysiology is loss of dopamine cells in the substantia nigra. That's where what we've identified. And also we have the inclusions that were discovered by 1912 by Frederick Louis in the brainstem. These are alpha-synuclein inclusions called Lewy bodies. And although we talk about Parkinson's, it being a dopamine disorder, it's not just that. It's way more than that. Yes, it is Parkinson's. Yes, we do see pathological changes appear as early as 3 decades before the clinical signs, but it's not just because of loss of dopamine neurons. We also see other neurotransmitters being affected. We see norepinephrine loss in the locus coeruleus, serotonin depletion in the raphe leading to mood disorders, anxiety, depression, etc. We also see an increased acetylcholine turnover, which could lead to those increased rates of dementia and Parkinson's. So, and there's more. And so are some thoughts of now trying to prognosticate or stage the disease based on the neurotransmitters. or other biomarkers that we see earlier on before the motor features start coming on before phenoconversion. Now, the cardinal features still remain, the diagnosis still remains clinical. The cardinal features are resting tremor, bradykinesia, slow movements, and rigidity. It's muscle tightness, rigidity, and also postural instability and gait abnormality. So these are all the motor features. That's what we need in order to diagnose someone with Parkinson's. Unfortunately, there is no test, although I have to say there's things coming out in the last couple of years that we might see this paradigm change, but up till now, this is how we diagnose Parkinson's, a clinical diagnosis. Many decades ago, we have had Brack staging of Parkinson's disease that stating that the pathophysiology starts in the brainstem, which is stages 1 and 2. That's when we see the non-motor symptoms. We start seeing some autonomic dysfunction, some olfactory disturbances, people having trouble with smell, decreased sense of smell, etc. And as the pathology moves more proximal to involve more of the brainstem, a little bit of frontal lobes, we start seeing those sleep disorders set in and some minor motor disturbances. And later on, Brack stages 5 and 6, we see the involvement of the entire brain, where we start having these cognitive disturbances, dementia, etc. So this, we now know that the motor symptoms are the tip of the iceberg. There's so many non-motor symptoms that we see along the patient's lives that are affecting the quality of life. And we should start focusing more on these symptoms, of course, as well as the motor symptoms, with so many other non-motor symptoms that we really need to start paying attention. And thankfully, we do see now most in clinical practice that we're addressing most of these non-motor symptoms. Sleep disorders is definitely one. And like I said, this is what drove me to go into sleep disorders after I completed my movement fellowship. Their prevalence is significant. So we see them, I want to say almost every patient with Parkinson's has some type of a sleep disorder. It's anywhere between 66 and 90% of patients, and it's a big list. So the most common sleep disorder is insomnia. But it's a different type of insomnia that we see in the general population. I'll touch a little bit upon that later on. They do tend to have increased sleep latency, but it's mostly sleep efficiency and maintenance of sleep. Of course, REM behavior disorder, we'll talk about it extensively, daytime sleepiness, restless leg syndrome, periodic movements of sleep, and circadian rhythm disorders. This is the bulk of the complaints of patients' sleep. So you can see some patients have all of them. So it is quite it's quite a lot to talk about in a visit, which is why having a sleep clinic for movement or for DLB is useful, because you can certainly talk about all these in the allocated time for a visit. Now, as you probably know, the insomnia is a symptom of another medical disorder of its own disorder, sleep initiation or maintenance difficulty, which is what these patients usually have, despite having the opportunity and circumstances to sleep. This is symptoms need to be experienced for at least 3 months, about 3 times a week. This is what we see in our patients as well. In Parkinson patients, most of them report poor sleep. Most of them, if you ask them, they will tell you they're not sleeping well one way or another. The majority expresses fragmented sleep, and of course, followed by excessive daytime sleepiness. Most of them have, or a lot of them have, disturbed wakefulness regulation, which is the most common, the prominent complaint. But sleep maintenance insomnia is by and large the majority as compared to sleep onset insomnia. And they also have early awakenings. I rarely have patients who wake up later than 7 or 8 o'clock in the morning. So how common is it in the general population? I think insomnia numbers obviously vary, but it's somewhere between 6 and 30%, possibly a little bit higher. But in PD population, it's 25 to 80%. It's much, much higher. Again, most of my patients have insomnia, and we do see it across the board. There's a little bit of a difference between mild Parkinson's to moderate Parkinson's as it comes to insomnia. In mild Parkinson's, the majority report sleep onset and a little maintenance insomnia. However, as the disease progresses, we tend to see more, they complain more of maintenance insomnia. And sleep onset is not such a huge complaint. So difficulty maintaining their sleep is the most common complaint, and there's many reasons to justify this, and we will talk and go through and dissect the etiology in just the next slides. So this is typically what my day-to-day practice looks like when somebody complains about sleep, which is probably everyone. We start going down that list, knowing that insomnia, most maintenance insomnia, is either caused by frequent urination. That's the most common symptom. The patients wake up and then they have to go to urinate probably anywhere between 3 to, I've also heard 14 times, but 3 to 5 or 6 times is the average number that we have if they're untreated. So obviously that disrupts the sleep. On the most part, they don't have difficulties falling back to sleep, but that again varies depending on how well they're medicated. So I will talk to you a little bit about that. And the second most common complaint is difficulty turning over in bed. And they have difficulty because their muscles are stiff and they're rigid and bradykinetic. So, and they have problems with coordination. And turning over in bed, as easy as it might appear for someone with Parkinson's, is very difficult. So multiple times they will just sleep in one position. So go to bed in one position and wake up in the morning in the same position. That, of course, is very uncomfortable, and that can wake them up. So something that we always go through. And it doesn't always, the patients don't always realize that that could be what disrupts their sleep. When patients see their medications, the levodopa, wear off, they occasionally have muscle cramps. They wear off by having dystonia or muscle cramps. So that often wakes them up. And it's what we see is they wake up, they want to walk around. And as they're waking up, they also feel that they have to go to the bathroom. Sometimes it's a thing, right? So it's not just one complaint. We see nightmares is quite common. There is a little bit of a caveat to that because a lot of our patients talk about nightmares, but what they really mean is REM behavior disorder. So we really, again, have to ask questions. What is it that they really mean? And maybe they can't give us the answer because they're asleep and it's mostly their spouse or bed partner that is able to provide more information. They also have leg jerking, REM behavior disorder, although that will not wake them up, but their spouse will probably be the will give them a nudge and they will wake up. Their patients also have restless legs, periodic movements of sleep, which disrupt their sleep overall. Now, patients who have depression or anxiety may also be on SSRIs, so that would make some of their symptoms worse. We do see that it's a risk factor for their insomnia, for their maintenance of sleep. And the duration of levodopa therapy, and of course, the duration of the disease. So more advanced stages present with more sleeping problems. So like I said, motor symptoms are some of the causes of disrupted sleep. So although tremors tend to go away, and they do go away when someone's asleep, I have it up there because what happens is if they wake up and they start having tremors, a lot of the times they complain about them because they can't fall asleep. So it prevents them from going back to sleep if they're shaking. So that's something that it frequently comes up. And again, muscle stiffness, dystonias, inability to turn over in bed, these are all motor symptoms. And in Parkinson's, if you have motor symptoms, the best way is obviously to treat them and make sure that they don't have off time. And I'm sorry, I have a little bit of a cold. So you might want to make sure that they they don't wear off at night. So we know that patients who have motor fluctuations during the day tend to also have these nocturnal motor fluctuations as well in their sleep. So motor fluctuations, just briefly, when patients take their levodopa, it starts to become efficacious, starts working in probably 40 minutes to 1 hour, and then it wears off in 3 to 4 hours. And the patient starts having these motor fluctuations. They're on well-controlled symptoms and the medication wears off, and they're off with less controlled symptoms. So they might find themselves having tremor again, or stiffness or rigidity. This can happen also at night, especially at night if they're not treated. So that's when we get the nocturnal bradykinesia, rigidity, tremor with nocturnal awakenings, and so on. So basically, we're trying to make sure that they don't wear off at night. How do we do that? It's interesting that I find that I see patients from being treated by either general neurologists or movement specialists that are not really focusing on sleep. So treating their symptoms in sleep, but it makes a big difference. So we always focus on providing them with something that would last throughout their sleep, whether that's long-acting dopaminergic medication in the form of levodopa, levodopa CR, a dopamine agonist. Rotigotine patch is also very good because it improves morning off time as well, and it provides a very steady state of medication on a 24-hour level. And the levodopa gel, the pump, for some patients is very helpful as well. And DBS, deep brain stimulation, although it's not a medication per se, it provides continuous therapy. It stimulates electrical therapy that controls motor symptoms. So anything that would control symptoms throughout the night will improve sleep quality and has been proven to contribute in improving sleep and quality of sleep, duration of sleep, etc. And patients, it's always very exciting once we turn on the DBS. I usually see them a week later. They always comment on sleep without even me asking. They're like, haven't slept so well for many years. And that's because their motor symptoms are well controlled. And that makes us understand the significance of controlling their symptoms when they're sleeping. Restless leg syndrome is no different in Parkinson's disease as with the rest of the population. It's still an urge to move their limbs and uncomfortable. It's tricky. They're moving their legs they have the sensation at rest and periods of inactivity. It's interesting because patients with restless leg syndrome who have Parkinson's occasionally confuse their RLS symptoms with dyskinesias. So again, that's something to think about if you're treating patients with Parkinson's. Are they really talking about RLS, or are they talking about dyskinesias? Overall, they did look at the prevalence of RLS in the PD population. It's much higher than in controls. We see that it can be anywhere between 52% up to half the population of Parkinson's can have RLS as compared to controls. Again, it's really good that we can use dopamine agonists in these situations that are very helpful. In terms of the pathophysiology of RLS, there's a few thoughts whether RLS and Parkinson's share a common dopaminergic pathophysiology, given that therapy and treatment is the same, or they could have a different mechanism, that idiopathic RLS. So is it RLS in PD, or is it idiopathic and different than idiopathic RLS? Are they same pathophysiology? There's some unanswered questions. And or are they two different entities, RLS and Parkinson's? It's up to debate and more research. And the sleep disturbances in RLS are very similar to the rest of the population. They had trouble falling asleep. They have fewer hours of sleep, and have an insufficient sleep with more awakenings. And in patients with Parkinson's, if they wake up, they might again have motor symptoms, which prevents them to go back to sleep, and it worsens their sleep than in control or patients who don't have Parkinson's disease. Periodic limb movements of sleep is also something that we do see frequently in people with Parkinson's. Management is no different than the non-PD RLS. Again, avoid caffeine, alcohol, medications. SSRIs, that's tricky because most of the patients are on some type of antidepressant, because mood disorders are very common in patients with Parkinson's. So again, we have to prioritize the therapy and how important is it to treat mood or RLS, etc. Iron supplement, we again practice the same treatments, dopamine agonist, and typically in patients with Parkinson's, dopamine agonists work very well. So we rarely need to try other agents. And it's when you see augmentation, it's really interesting. Not sure if it is augmentation, it's actually the disease getting worse anyway. So we know that patients with Parkinson's need more dopamine as their disease progresses. In terms of mood disorders, we always ask about their mood, anxiety, depression in patients with Parkinson, which could affect their sleep. It is much higher prevalence in controls. The patients are the majority of patients have some form of depression or anxiety. Another interesting aspect is when they wear off, their medications wear off, the dopaminergic medications wear off, they tend to feel more anxious. So that is another reason to make sure that the patients do not wear off their medications at night. They occasionally have hallucinations and psychosis in later stages. So that's also another thing to leverage when you are treating their sleep. And of course, behavioral, they tend to nap excessively. So it's very hard to keep them awake, but certainly that's where you need to start from, as it will weaken the nocturnal, the homeostatic sleep drive. And because of anxiety and depression, they will have a lot of rumination. Women tend to have more anxiety and depression and Parkinson's than men. So it almost always, when I have a woman who has Parkinson's, they tell me that they have trouble falling asleep and they have a lot of anxiety. And their wearing off creates and causes more anxiety than I do see in men. That's anecdotal. This is through my years of practice. So it is my priority to ask about mood and behavior. And I know that was very big with Dr. Auerbach when I was a fellow, we were further on practicing together. So it has been very successful sleep. And of course, dysfunctional sleep beliefs, and we use CMT quite frequently with those patients. Interestingly enough, some medications can affect the patient's sleep in many ways. So dopaminergic medication can go either way. But dopamine agonists can cause daytime sleepiness, somnolence. They complain of sleepiness. They may have sleep attacks. So if that is the case, you want to adjust doses or the type of medication taking or timing. However, interestingly enough, dopaminergic medication can cause insomnia. So infrequently, when I start a long-acting levodopa medication, they come back telling me that it's giving them insomnia. So then obviously I make changes, and there have been studies over which dopaminergic medications is more effective for nighttime and for patients' sleep, but there hasn't been really a good consensus as to what might be best, maybe a dopamine agonist, but again, every patient is very different in Parkinson's. There's not one Parkinson's, we know that for now, for sure. There's so many different kinds and flavors. Other medications, be careful of acetylcholinesterase inhibitors, galantamine, donepezil, or rivastigmine. We want to dose them in the morning. I do see multiple times that they take them before bedtime. I always switch, and they see a difference. So that can cause insomnia. Certain SSRIs, again, timing is everything. Move it on for the morning. If it causes insomnia, if it causes sedation, move it to bedtime or evening time. So keep in mind those medication effects. Autonomic dysfunction is one of the most predominant non-motor symptoms in Parkinson's, and I'm going to talk only about the bladder genitourinary dysfunction, which is affecting their sleep. I already mentioned how frequently they to urinate. The reason, so the patients typically feel urinary urgency. They feel that they have to run to the bathroom, even though they may not have enough volume. They have increased frequency, and it starts at night, but then eventually it progresses to have frequent episodes during the day as well. Part of it is a detrusor hyperreflexia. Like I like to tell my patients, there is a disconnect between the brain and the bladder. So the bladder almost has a brain of itself or a mind of itself. And they have uninhibited bladder contractions that leads them to think that they have to go to the bathroom. There's also sphincter bradykinesia, so delayed relaxation of the sphincter, the urethral sphincter, and they have difficulties with that as well. And so it has to do with the dopamine pathways. So the micturition reflex is suppressed, and that leads to bladder hyperactivity. So how we treat, we want to tone down these muscle bladder contractions. Of course, you want to make sure that there's nothing else going on. So we always refer for a urological evaluation. But if their bladder is, there's no other etiology, then we decide to treat with medications such as oxybutynin, tolterodine, trospium, etc. Amitriptyline could also help by improving sleep as well as urinary urgency, so keep that in mind. And of course, behavioral modification, limiting fluid intake before bedtime. So this is kind of how we work up our patient for insomnia in people with Parkinson's. Not just one thing. It's a little different than the general population. So obviously we'll look at mental health, motor symptoms, non-motor symptoms, pain. I didn't talk too much about it because that's incorporated more in the dystonia, muscle cramps, etc. So review the medications, any RS symptoms, and of course behavioral. You want to change their behavior over sleep. So this is the classic insomnia assessment in Parkinson disorder. It's a nice algorithm. And if despite of all these treatment or that we do in these conditions, most of the times I stop here. So depending on what is disrupting their sleep, most of the times I don't need to take further measures. However, if I have to, then we start with CBTI, and second line would be exercise, and I would say and here it is or, but the more the merrier. So BLT, light therapy. So light therapy there have been multiple studies about light therapy in dementia, Parkinson's disease, and have been helpful and efficacious. And if that doesn't help, then consider short therapy with hypnotics. One of my go-to is suvorexant. I find it's helpful. Usually dose them with melatonin, but not so much for insomnia, but mostly for behavior disorder. So always making sure that we don't dose them with the Z drugs. But yeah, so far suvorexant has been quite helpful. So switching gears from insomnia to REM behavior disorder, I know most of you in this crowd don't need any introduction about what REM behavior disorder is, but I know there's a few trainees in this room, so REM behavior disorder is loss of REM metonia with dream enactment. And the criteria is repeated episodes, not just one, but repeated episodes of vocalization or different types of behaviors that are either documented in a PSG. So what they see is those behaviors of muscle activity in REM, or reports of dream enactment. Usually when it happens, it's repetitive, and usually the bed partner reports these, very vividly reports a dream enactment. So we need to have evidence of REM sleep without atonia and PSG. You don't necessarily have to have the behaviors, but as long as you document the atonia, the lack of atonia in REM, you can set the diagnosis. So this is very disruptive behaviors during REM. We do have so many different versions of REM behaviors, where it could be screaming, yelling, kicking, thrashing. One of the most dangerous, I should say, is when they accidentally fall out of bed or start walking out of bed and leaping out of bed. So that's how they lead to injuries, or even kicking or hitting or punching their spouse, their bed partner. That's very dangerous for them. So when they become very active, it's a big concern. Now, it's the prevalence varies depending on it. Going through the literature, it's definitely prevalent, but to what extent, it's still debatable. But we do see it quite prevalent in patients with Parkinson's disease. And what is very important is a very powerful and strong predictor of synucleinopathies, not just Parkinson's, but also Lewy body dementia, MSA. REM behavior disorder can precede the onset by 12 years before the phenoconversion, before the diagnosis of Parkinson. It could be even more. It could be, I'll talk in the next slides, could be even 30 years before the patient start manifesting motor symptoms. There is the de novo Parkinson cohort, which is a cohort with newly onset symptoms of newly onset Parkinson's. A reported prevalence as much as 25% in the patients with Parkinson's, as compared to 2% in healthy control. So there's obviously much higher prevalence there. It is related to pontomedullary dysfunction of the structures that regulate sleep. And the main concern is injuries to the patient, injuries to the bed partner. I've seen over the past year, I think I've seen about 3 major injuries, big lacerations. Usually interesting, it's interesting that patients have either fractures or big lacerations around their face, because there's the bedside commode or there's the table next to them. So when they thrash, they probably get injured in the corners. So they have big lacerations around the eye or black eyes, etc. So we do see it. And obviously you want to treat before you get there. So I have a very low threshold of treating REM behavior disorder. And patients who have dementia or hallucinations are at a high risk. Men are at a high risk of having REM behavior disorder. So maybe they're reported more. Antidepressants, it's unknown whether it's triggering it, unmasking it, or it actually is etiological. Probably not. And alcohol withdrawal. So there's been a lot of studies following the patients with idiopathic REM behavior to see the phenoconversion and what's the course. And in neurodegenerative, there was this study 10 years ago where they looked at 100 patients with idiopathic REM behavior disorder at the time, and 15 years later, 82% of the patients had phenoconverted to some type of neurodegenerative disease. The majority was Parkinson, 16. phenoconvert into Parkinson's, 14 Lewy body dementia, 1 MSA, and a few MCI. So the risk for a neurodegenerative disorder from patients who have idiopathic REM behavior disorder at a 5-year risk is 35%, 10-year is 75%. And if you keep on following them, I'm sure it's much more. There was another meta-analysis, longitudinal studies. They actually revealed that 97% of REM behavior disorders converted to some form of a neurodegenerative disorder after a follow-up of 15 years. So almost all of them did. The majority developed Parkinson's disease, and DLB was the next one, the next big neurodegenerative that developed. And then what followed was MSA, MCI, Alzheimer's, much less so. So by that, we're starting to think about what happens here. What happens at the time that this Parkinson patient has not developed motor symptoms? Is there a biomarker? Is there something that we can find to be able to characterize or diagnose Parkinson's versus DLB, perhaps, or diagnose whether that patient is going to develop alpha-synucleinopathy? I remember as a fellow with Dr. Auerbach, we had this discussion. That was like 12 years ago, I think. We had this discussion multiple times. Should we tell the patient? Should we not tell the patient? What, and if we tell them, what are we going to tell them? So I think 10 years forward, or 10 years plus a few more, I think we know much more and of what happens here and how can we prognosticate what that patient with idiopathic REM behavior disorder, what they will develop. And there is the MDS research criteria for prodromal Parkinson disease. So this is a newer category of Parkinson, so to speak, this prodromal Parkinson disease, which involves certain markers of that would risk, or markers for prodromal PD that increase someone's risk for developing Parkinson disease. And of course, it's a long list, but the highest level of evidence or risk is olfactory loss, REM behavior disorder, constipation, depression, and anxiety, and of course, other symptoms as well. So we're looking at motor symptoms, some of the autonomic dysfunction, rectal dysfunction, urinary dysfunction we talked about, some visual problems, some testing such as DAT scan, PET scan, etc., and alpha-synuclein biopsy as well, though this is GI biopsy. So we're starting now to conjure or gather all the different markers that could give us a better understanding about the patient's trajectory, where and if they will develop some type of alpha-synucleinopathy, and most here in particular Parkinson's disease. So up till a certain time, we knew about the clinical phase. The patient came in the clinic, had motor symptoms, diagnosed with Parkinson's disease. However, now we are learning that there's this prodromal, preclinical phase. Parkinson does not start here. This is what we see, but there's so many things we don't see 10 years, even 30 years before the motor symptoms start. And so there's this risk phase where patients may have genetic markers. Maybe they have some environmental exposure to pesticides or chemicals. So this is what increases the patient's risk. And then there's a preclinical phase with blood and tissue biomarkers, biopsies, imaging, etc. And then we start noticing that in the prodromal phase, which is usually 10 years, it could be much longer, obviously up to 30 years, we start noticing some non-motor symptoms. REM behavior disorder is the big one, and autonomic dysfunction, olfactory, depression, somnolence are some of the few. So This seems to be now a different spectrum, a different continuum, starting from normal 25 years before the diagnosis of Parkinson's disease or Parkinsonism, because we should also think about Lewy body dementia. So there's a recent study from Dreams to Parkinsonism that was published in Brain in 2019. It seems that the first symptom that they have noticed was hyposmia, starting with that symptom, then on 20 years, 15 years later, we noticed the rematonia loss, then some autonomic dysfunction, and eventually the patient phenoconverts with motor symptoms or cognitive dysfunction. We'll talk a little bit about that. So this is one of my favorite recent studies have been they multi-site international studies looking at the clinical markers in prodromal Parkinson disease and Lewy body dementia. And they started with a very, very high number of over 1,000, 1,200 patients, and followed them longitudinal over years. And they did see that there was a phenoconversion of 80% as the other studies. So similar to the other studies, they saw a phenoconversion of 4.4% at 1 year, 18, almost 20% at 3 years, and 30 at 5 years. And but they didn't stop only at that. They looked at other features. They looked at the the MDS prodromal markers that I just mentioned before, and they looked at all of them, and they followed patients who phenoconverted to either Parkinson disease or DLB. And what they found was very interesting. Overall, the phenoconverters, so just to show you, here is when they phenoconverted, and these were the different scales that they used. This is the MDS, UPDRS-1. This is more the motoric phase, the SOPA, the autonomic phase, and MoCA. So what they saw is there was an overall greater progression in the motor, the olfactory, the cognitive, and certain autonomic markers in the people who phenoconverted, and they were almost parallel. So there's nothing really to stand out between Parkinson's and DLB patients. However, the only robust differentiating clinical marker was between the PD first, meaning they phenoconverted to Parkinsonism first, versus DLB first, was a cognitive decline. And you can see it very well illustrated here. So this is the DLB patients, and the Parkinson is this one. So you see a dramatic difference. When they phenoconvert here, you have a significantly lower MMSE, same thing with MoCA, as compared to patients with Parkinson's disease. So this was quite striking, and posed a different question. Taking that information into account, can we really predict now the type of alpha-synuclein disorder? So we know that the pronounced marker is cognition, and we saw a much faster or improve I should say a marked difference in cognition for people with DLB. So there was a different study that they looked at. They did serial neuropsychiatric testing in patients with idiopathic REM behavior disorder until they phenoconverted. And they looked back at the different parameters of neuropsych testing. It's very interesting to see that they looked at the trail testing, and they looked at the early cognitive dysfunction with this test, showed it was very sensitive for cognitive decline early in the disease. So we do see that both for DLB and for Parkinson's, they both had a very parallel trajectory, and the rate of change was more or less the same. Now, what was interesting, though, is that the progression of the different types of the cognitive changes differed. So there was attention and executive dysfunction was the strongest predicted value for dementia and for Lewy body dementia. So we saw this progression between early cognitive decline. This is the attention and executive functioning. You see how the executive functioning tends to be more affected in patients with Lewy body dementia. And then the episodic memory was mostly affected. So you see that it is almost a differentiator. It is actually a differentiator between Parkinson's disease and Lewy body dementia. So the decline as a continuum, the cognitive decline is executive dysfunction, then attention, and then memory and visuospatial. And this is what differentiates DLB between DLB from Parkinson's disease. Another interesting study looked at the timeline of REM behavior disorder in all alpha-synucleinopathies. So what they looked at, and that was very interesting also clinically, is patients who have Lewy body dementia. So let me just explain what this is. So this is patients with, the shaded line is when they notice REM behavior disorder, and this is when they were diagnosed with REM behavior disorder, the bold line, and this is when they phenoconverted. So for patients with Lewy body dementia, they had noticed REM behavior disorder before they phenoconverted. Patients with Parkinson's, they started noticing REM behavior disorder after the phenoconverted, and they were diagnosed later. So breaking this down, you can also see this is Parkinson's, this is Lewy body dementia. They've had REM behavior disorder, of course, even 30 years prior to the phenoconversion. And Lewy body dementia patients were 3.5 times more likely to experience isolated symptoms of REM behavior disorder. So these patients who come in and only have REM behavior disorder, nothing else, as compared to patients with Parkinson's who phenoconverted first, they started having motor symptoms, and then they noticed that they have REM behavior disorder. This study also looked at 10 years after phenoconversion, which is around here, and they said that both DLB and Parkinson's patients can equally develop one of the considered alpha-synucleinopathies, so either DLB or Parkinson's. So that's also something interesting to know. Now, seeing the RBD on a different lens, genetics. So interestingly enough, they overlap with GBA and TMEM175. They overlap between dementia with Lewy bodies and Parkinson's disease for patients who have REM behavior disorder. It's interesting to note that SNCA, which causes the 5 end of the gene, causes more Lewy body dementias, and the 3 end of the gene causes more Parkinson's disease. But you can also this differentiates between the two. So that's something also interesting to know. Now, going back to clinical management of REM behavior disorder, we really want to minimize the dream enactment behaviors. If they're just talking and vocalizing, and that is confirmed by the bed partner, there's no risk potentially or imminent risk, so maybe you can hold off on treatment at that point. But you never know when you're going to have a risky behavior. So like I said, my threshold for treating is much lower. You don't want to treat them after they've been injured. So always make sure that you make that clear to the patient, and usually they're pretty good in understanding that. One caveat to that, what I've seen clinically, is you always explain this, you give them the medications, and they come back and they tell you, oh, I didn't take it because it didn't help me. And then you ask them, what do you mean? Said, oh, it didn't help me sleep better. So there's a lot of misconception between the patients, what they understand as REM behavior disorder, and sometimes that would affect their compliance with treatment. And try to make them, to ask them not to engage in stressful discussions or action movies or horror movies, because that seems to worsen their episodes at that particular night. So try to engage in more quiet bedtime routine and meditation. So education and counseling takes a long time, and it is a disease. It is a disorder that most know or have heard about. So it takes some extra time in educating them, and especially to help, like I said, with compliance. And these are the medications. I'm going to go a little bit faster now because we're afraid we're running out of time. Clonazepam, melatonin have not been proven to help, but anecdotally they are helping. Also consider sleep apnea as an aggravating factor. And newer aspect in how to think about REM behavior disorder and DLB and dementia overall. Can dream content predict cognition? There was an interesting article about a couple of years ago about this, and they actually did find a negative association between, positive association between negative emotions and dreams and a reduction in MoCA scores after 4 years of a study of 58 patients with Parkinson's disease. So they concluded that it is a predictor of cognitive deterioration. So if your patients start having worse and worse, more active or bizarre or negative, like more action, but like dangerous dreams, that is a sign of cognitive deterioration, possibly because there's some type of correlation between dream aggressiveness and frontal lobe cognitive dysfunction. Excessive daytime sleepiness is another common symptom that we see in Parkinson, mostly because they don't sleep well. So there's also that, but in addition to that, there's an impaired arousal system, circadian rhythm disturbance, dopaminergic medications, and quality of sleep overall. So you have to go down the list, and also behavioral. They might be sleeping a lot during the day, not sleeping at night, and then that creates more excessive daytime sleepiness. We do manage their sleepiness reviewing their medications. Dopamine agonists cause a lot of sleepiness, and make sure you keep the patients awake with daylight. Here in the South, it's very for me to recommend taking a walk outside. Not sure you can do that up there in Boston. I always struggle with that. When I was practicing, you can't really encourage patients to walk outside when it's cold and snowy or rainy, but at least here they can get more sunlight exposure. That is very helpful and also encourages them and in increasing their physical activities. If that doesn't help, stimulants can be effective, although that's it's very difficult to prescribe them, be covered by insurance, and they're not often as effective. Always remember that if someone's excessively sleepy during the day, caution them about driving. Circadian rhythm disorders, that is something we also see in people with Parkinson's, because we do have many reasons for that. Circadian rhythm, degeneration of the SCN nucleus. There's also degeneration of the cholinergic nucleus and the nucleus basalis of Meinert, degeneration of dopamine-containing cells in the retina of patients with Parkinson's. There's a reduction in the expression of melatonin T1, MT2 receptors. So there's a lot of pathology that can lead to circadian rhythm disorders. There's also an interesting lack of variation in the plasma melatonin concentrations. So there's not good diurnal melatonin, also cortisone secretion. So this is how we treat circadian rhythm disorders, more like similar to any other patient. With bright light therapy is our goal. Get exposed to bright lights or sunlight outside, natural sunlight, melatonin, CBTI. Again, suvorexant has shown to increase total sleep time by 28 minutes versus placebo, and consider medication. And I'm just going to end by a recent work that was published. This is a work we did at BU with BU Physics. We looked at the networks of corticomuscular interactions in sleep and neurodegenerative disorders. Dr. Auerbach is aware of this study. And what we did is looked at the network coordination between EEG and cortical EEG, surface EEG, and leg and chin EMG signals in the awake and sleep stage in normal patients and patients with Parkinson disease. So it was very interesting. Our findings were very interesting. It showed a big change and difference between Parkinson disease patients in the awake state as well during sleep. So we saw a breakdown of network interactions during all stages: awake, light sleep, deep sleep, and REM. And I'm just going to show you some of the findings that we had. So I know this is a very busy slide, but just to show you the major differences. So this is basically the different stages of sleep and the right and left hemisphere. This is comparing cortical areas with the EMG of the leg EMG. And this is the healthy group, this is a Parkinson's group. We did see a difference between the different stages, between the different disorders. And interestingly enough, looking at here, I'm going to point out REM sleep. So the connection between the cortex and EMG and muscle, we see a stronger associations of this between the two in REM sleep as compared to normal. This is healthy group, this is a group. So it was stronger association, and then there was a decrease in light sleep as well. So these are some findings, and perhaps this could lead to a biomarker. Another biomarker just includes data from the PSG. That's all it's needed. So that could be something we're looking into. It is just very novel, very new. So we want to look further into this. And maybe it's new information about the nature of REM behavior disorder and sleep in Parkinson's. And with that, I will conclude my talk. So remember, insomnia, the most common sleep disorder in Parkinson's, multifactorial. REM behavior is the most powerful biomarker of alpha-synucleinopathies at this point, and there's more studies, ongoing studies, and more information that we are looking into. And we need more studies to stage, prognosticate, and predict alpha-synucleinopathies. Thank you so much. This is San Antonio. This is our center. And thank you for your attendance. Happy to take your questions.
Thank you very much. I think we have time for maybe one or two quick questions. I think everybody's unmuted. I have a quick. I've read about this. Parkinson's disease patients have sleep benefit. Do you see that as is that a large magnitude, that sleep benefit that you see in your clinic?
There is, and I don't know of a large study that would support this. I was very interested to see, but clinically I do see it, and in the reverse, I see the deterioration when, for whatever reason, they lose their sleep. I see a deterioration in motor symptoms and also in mood, and it could even lead to psychosis. So it's also the reverse. And it is very important to keep their sleep very healthy. And again, I don't see it. I wish I could see more focus on sleep, because it's the continuum of their therapy, and it more of a holistic approach. Is not most. I see a lot of the therapies being focused on during daytime, as it should, but also let's not forget their sleep, because it's so important for them.
There are questions in the chat.
Mm-hmm. All right. So I'll start from the top. Okay, there's a lot. How would you time light therapy in Parkinson's? So yeah, I don't think that would be any different than any circadian rhythm disorder that we see, whether we have advanced stage or delayed sleep phase. Typically, one thing that we urge the patients is when they're having this daytime sleepiness, and a lot of the times they have something else called postprandial hypotension. So after a big lunch, their blood pressure can drop because they lack autonomic control. And that's when they start feeling sleepy and tired. Obviously, you want to prevent that by keeping the blood pressure intact, but a lot of them tend to nap during that time. So I urge them to get exposure to light or be active or start doing something physical so as to stay awake. And that usually helps. Although it's challenging in situations such as a nursing home and more advanced stages, that's really, really challenging to do. And it takes a lot from the caregiver. So it's doesn't always help, but it's certainly when they adhere to this, it's very helpful.
Yeah, I think we're past time. I'm not sure. I suppose if people want to stay on, you had one or two other questions you wanted to answer, we could perhaps do that.
Yeah, I think it's one question. What is the explanation for the dramatic change of dream content from what it had been in the past in REM sleep behavior disorder? I'm not so sure about a dramatic change. It seems that the negative symptoms, it's almost like there's some frontal lobe dysfunction, which you can argue that there's no control there, it lacks inhibition. So that's why the dreams become more wild, for lack of a better term. So this is something that's very new. So obviously we need to look more into it.
Maybe we should stop there.
Okay.
Thank you so much for such a wonderful lecture, Okeanis. Wonderful.
Thank you for inviting me, and I hope we touched a lot about sleep and Parkinson's.
Thank you.
All right. Okay. Thank you for listening.
Have a nice day.
Bye.